Thank you. Thank you so much, Jane. And I know there was so much information in there. The slides will be available latterly. There's lots of really useful information. And I've only known Jane now for a couple of months, and I know that you're so helpful. So I'm sure we can continue to collaborate with you and learn from your experience. Last but not least, that's why we've got two of you, because then I don't know who's last or least. So I'm going to introduce you both. We have the MELD-B team here. And yeah, so Lynn, I think it looks like you're going to take the podium first. So over to you.
Yeah, thanks. Yeah, hello everyone. My name's Lynn Laidlaw and I'm a patient and public contributor and researcher. I live with, but I don't suffer from, because language is important, multiple long-term conditions, including a rare disease. And Simon and I are going to present to you about some of the work we've been doing on the MELD-B project, namely our qualitative evidence synthesis and looking for the lived experience of multiple long-term conditions and data.
Thanks, Lynn. And I'm Simon Fraser. I'm a public health doctor down in Southampton, and I was previously a GP, and I'm one of the co-leads for the MELD-B project with Nisreen.
There. Yeah, so we wanted to start with some background. So multiple long-term conditions develop throughout the life course, and people experience significant impact on their lives. And this has been commonly described, especially recently, as burden. But the specific mix of conditions that people have can cause differing impacts. People with multiple long-term conditions aren't a homogeneous mass. And MELD-B has focused particularly on early onset, and we know that people living in deprived socioeconomic circumstances develop multiple long-term conditions earlier.
So what we tried to do in the MELD-B project was we started with a qualitative literature review, which was a very large task, and I must mention Amelia Holland, who's led that work, to try and understand the lived experience. What does it really mean to live with multiple long-term conditions? And then trying to go from there, the difficult step of saying, if you understand what it's like to live with multiple long conditions, which of those things can you see in data? So a little bit analogous to what Hajira was just saying about social care. Which things about the lived experience can you see? Can we characterize that in data? We also did some consensus work, or doing some consensus work, to understand which is the most important things of those for patients. And then can we look at clusters which are based around the idea of burden, or because we were influenced strongly by our PPI group, we stopped calling it burden. We've started calling it work and workload, the workload of living with multiple conditions. And then trying to think about prevention, because prevention suddenly becomes not just about conditions, but about the workload. And I'd just like to say that members of the public and patients have been, an integral part of our team all the way through. So
yeah, I think we were allowed to make a difference to the research, is how I would characterise it. So this shows the themes of work we identified from our qualitative evidence synthesis, and they're complex and multifaceted, but not just from the clinical research and medical management point of view. The work involved from the person experiencing multiple long-term conditions is complex too, and I'm not sure that we really surface that enough. And arguably, themes such as medication and investigating and monitoring are captured and have been studied. But those such as the emotional work and accumulation of complexity. And this includes issues such as biographical disruption, which is how we understand ourselves and our place in the world, are poorly recognised. So Simon, what do we see in routinely collected data?
good question, Lynn, good question. What do we see? So we've used a couple of big data sets, as many of the AIM consortia have. And to cut an extremely long story short, we so far have developed a number of, we've approached this in two ways. We've developed a number of code lists that are trying to reflect some of those themes of lived experience. So not just the very biomedical ones, but also looking at codes for things like emotions, looking for codes for symptoms. And we've also engineered some concepts of sort of thing that many of us are doing around things like numbers of appointments, numbers of medications, and so on. But also thinking about, in terms of accumulation, the rate of accrual of long-term conditions as being an important factor. So again, to cut an extremely long story short, here's an example of looking at a very high level at the representation or the recording of some of these concepts in routine data. So these data are from CPRD. These are looking at the 8 themes that we mentioned. Now, this, as I say, it's at a very high level because within each of these themes, there are many different code lists and different concepts. So if you look at the top left, for example, you'll see emotions. And I can tell you that there's at least 12 code lists of different emotions sort of summarized into one there. And you can see with this particular cohort of 8 million people that it happens to have been divided into people with a history of mental health problems and people without. And you can see that emotions are slightly more strongly represented in people who have a history of a mental health problem. But look at the proportion, if you can see it on the left there. We've got about 4% per year of people having a record of some form of emotion. Compare that to the investigation and monitoring, where, as you would expect, because it's about monitoring long-term conditions or it's about monitoring drugs, you've got about 60% of people have some kind of code related to an investigation or monitoring activity. So that's really high level. It's interesting to see some changes, some dips in COVID and various other things, but it only scratches the surface of everything that sits underneath all of those concepts. And an important concept to mention is that we have strongly recognized the potential for bias and information loss, both on the left side, taken from the clinical setting of the patient sitting, talking to the doctor, what they choose to record, what they choose to code, how that's summarized, how that's brought together, and how we present data, underrepresent some of these things. We've recognized on the research side, doing qualitative research, there's selective coding, there's selective recording, there's selective reporting. All of this risks bias.
Yeah, and I mean, we need to ask ourselves, who decides what's captured and documented in data? And do we collect data from a patient's point of view, or is it collected about us? And I read all the 46 papers in the qualitative evidence synthesis looking for evidence of patient and public involvement. I found it in 5 out of 46 papers. So we're asking, where is the voice of the life world in all of this? So how could we do this better? So, I mean, what we're asking is, why do researchers and clinicians work in relation to multiple long-term conditions, but the people affected are described as burden? Whose burden is it anyway? Burden is surely subjective and we shouldn't be assigning it by others. And I think recognising the work for everyone denotes parity. And, we feel that the experience of living with multiple long-term conditions is complex and multifaceted, and it often involves a great deal of work for the people affected that should be recognised. And these themes of work are not static. They ebb and flow, and they're personal to the people concerned. And you have to understand them and their context. And really, we need to work with people living with multiple long-term conditions to understand the best way to capture this work in the data using AI and other methods.
And just to finish, I mean, I think it echoes what Dilip was saying earlier, that if we use data-driven cluster analyses to drive policy, we're missing part of the story. And I think it's really important to recognize that. And we should consider as well what constitutes evidence. So we're just using quantitative evidence, or do we consider qualitative evidence as well? And there is potential for us all to bring greater humanity to MLTC studies. I think I'm going to stop there, Mon, and we've got the red card, so